Yeah.
Hello, good morning. Can you guys hear us?
New York, can you hear me?
Yes, we can. Go ahead.
Yes, we hear you. Great. Great. A warm welcome to Münster, Germany. This is Martin Aussermann. We have a case for you to present. And with me at the table is Dr. Sensebat on the other side, and in the back, Dr. Stahlhoff. And our scrub nurse is Leonie, and also we have help from Karin. Now Dr. Stahlhoff is going to present you the case. Please.
Great, thank you.
Maybe we can have the first slide.
So yeah, hello to New York. So we're going to treat an 81-year-old male patient here. The next slide, please. The patient has been treated by EVAR with a talent endograft 13 years ago. It was an aortic monoiliacal solution with occlusion of the left common iliac artery and then implantation of a crossover bypass. Now he has an enlargement of the aneurysm sac because of type 1A endoleak due to due to progress of the aneurysmatic disease, and he also has a iliac artery aneurysm on the left side below the plaque occlusion. The patient has known coronary artery disease and has also been treated by stenting in the past. So next slide, please. Now you can see here our schematic drawing. As you might recognize, there is almost no space or landing zone left below the right renal artery, but there's some space left below the left renal artery. So our plan is to implant a tube graft and to preserve the right renal artery with a Chimney stent. When you have a look at the drawing, on the left side there is the iliac artery aneurysm. Due to the fact that the right hypogastric artery is already occluded, we want to treat this aneurysm by preserving the left hypogastric artery by implantation of a flexible covered stent from the external iliac artery to the hypogastric artery. Dr. Aussermann will now explain the details.
So thank you. I want to show you what we have done up to now. We start with a cut down of the left axillary artery. Maybe we can show it. The left axillary artery. It's a nice access, not only for one sheet. You have in most cases space for up to, I think, about 3 sheets. But in this case, we only plan one chimney endografting. With a reason, our patient is 81-year-old, and our reconstruction has not to last forever. And we want to treat him safely, and we don't want to have, for example, a cerebral infarct or something like this, and therefore we decide only to use one chimney from above. What we also have, we need access for the imaging, and we had only one perfused iliac, and therefore we make 2 cut downs just below the crossover bypass because SFA is very large. It's about 8 to 9 millimeter, and as you may see here on the right side, we had a small cut down, and we put an 8 French sheet at the moment, and a little below a 5 French sheet for imaging. Yeah. On the other side, we made a cut down 2, and this is for our banana technique on the left side. We plan to place a 12 French sheet later, and then we can try to preserve this hypogastric artery from below having a flexible covered stent from the external to the internal artery. In the common iliac artery, they placed 2004 in another hospital an occluser, a talent occluder, so that we have to treat it like this. But our first aim is to extend the proximal landing zone above the right renal artery to seal the aneurysm proximally. Now I like to show you our first fluoros. So we start from below with our cut downs, and here you can see the crossover bypass and the retrograde filling of the hypogastric artery on the left side. Yeah, I think we have to look at it later. Yeah, you can see we go through the superficial femoral artery, and below the old talent graft we have a very severe kinking of the external iliac, and the hypogastric artery on the right side is occluded. So the next step was to cannulate all this up to the ascending aorta, and we place then a double curved Lunderquist for the later endografting. Then we come from above, maybe you can see the second wire, and we go down to the descending aorta and do our first angio, and you can see the right renal artery origin is lower than the left one, and we think we have enough landing zone to extend the cuff down up to the left renal artery. So the next step was we go for stiff terumo, and we were able to place an 8 French sheath from above, and we could cannulate the right renal artery from above. Our planning was so we tried to get access to the a little bit upward facing right renal artery from above, and when it doesn't work, we are prepared to come from below and create a kind of sandwich. But in this case it was possible to come from above, and we were able to change for the Rosenwire. Here we look at the very distal location of the, and then this is already the Rosen graft and the 8 French sheet. I think we have a curvature, and therefore I plan to connect this kidney with a flexible wire band from above. So this is where we are. We also like to use the fusion technique, and maybe you can switch just for the fusion screen, and then I can show you how we do it. Yeah, yeah, now you can see it. So you can see I make two views, angio from anterior posterior position and a lateral view of the spine. And then we can start the automatic registration here like this. And as you can see, maybe it works, sometimes it works not. It's a prototype. Yeah, but you can see this automatic registration seems to put it too high. Then we can go to the initial position, and we could it registration manually. So I put the renals in front of our, and I think the spine is not too bad. And then I go to accept. So now the machine knows where the CT projection is. Before you have to register the CT scan and mark the origins of the target vessels. And now you can see we have here a mesh And then we go to the overlay function, and we have a look how it works. So maybe, yeah, you can see it works not too good at the moment. We have to correct this. Sometimes it works very well, sometimes, but I can correct this now a little bit. Maybe like this. And then we can go ahead. So looks better now. I have to correct again in the other direction. Maybe like this. Except not bad, I think. Okay, now we have a little help from this fusion technique, and we go ahead with our procedure. So the next step would be, you know, the Lunderquist very much straighten the right iliac, and we have to test if we come in the correct position. I think, therefore, we need first a 14 French sheath and have a look how it comes in place. 14 French, ne? Hast du da noch eine andere, die dicke? Die ist noch besser. So I take a 16 French sheath because the cuff is also a little bigger. If you have any question, feel free to interrupt.
So what kind of cuff are you planning to use?
So I try to go, so you can see we have here some resistance, but maybe we can manage it with the endograft. Was willst du? Nein, nein. Den Cuff dann, den ersten 36er, ne? So I try to come above with the cuff. Wenn das nicht geht, dann brauchen wir noch mal eine längere Schleuse.
Can you hear us?
I can hear nothing from New York. I can hear nothing.
The question was, what type of cuff are you planning to use?
Okay, I hope you can hear us. The next step would be we've taken a tube from Endurant. It's a diameter of 36 is prepared. Okay, gut drücken. Ne? And it's 70 millimeter long.
17 millimeters.
And if this is not enough, we can use another one to extend it in the existing talent endograft.
70.
So hopefully we come, yes, it goes through. You can see it. A little hooking, but not very severe. Okay, I have just one eye on the fusion. I think maybe here we are in a sometimes good position. I drive my C-arm in a position we had an angio made before. I just do an overlay. Yes, not bad. And I think now I would place first my Viabahn before. So the right renal artery has a diameter of about 6 millimeter, and therefore we take a 7 millimeter Viabahn. We just change the position. den Bildschirm wieder umstellen, bitte. So as you can see, I think the 8 Frenchies from above, it's very difficult to bring inside the target vessel, but I think the Wirebahn will do it, 7x50 Wirebahn. So we take a 7x50 Wirebahn.
Dr. Austermann,
So
can
eine
you
Vergrößerung,
hear us?
Yeah,
Make
very
it a little bit louder.
It's too louder. We need it louder.
We need it louder.
Dr. Austermann?
Yes, now I hear you.
Yeah.
Okay.
There you go.
Morning.
Good morning,
Good
Professor.
morning, how are you? So I would like to know why you
Fine,
are
thank you.
using a Wirebahn in this case. The Pericles registry showed that the best combination is a flexible stand graft in combination with a balloon expandable cover stand.
Yeah.
Perhaps you
in
can
this
explain
case,
why you decided to use the Wirebahn in this case.
Yeah, yeah. In this case, you can see the right renal artery is upward facing. And I think if we use only the Advanta stent, maybe we create a kink distal of the Advanta and have a occlusion later on. And therefore, my plan is to place first this Wirebahn to keep the wire in place and then place another Advanta or anything else inside this Wirebahn. I think the Wirebahn is the most flexible stent graft, and I think this bridging stent graft will describe this curve maybe the best. So you can see I just place the Wirebahn. I do, geh mal auf 16 bitte. Another angio.
One thing in regards to, you're using a double stent technique where you'll come in and use a Viabahn and then either self-expanding or balloon expanding stent. We've converted it for a lot of these of coming in and actually using the VBX, which is the new Gore Viabahn with balloon expandable stents. That's very flexible. Have you had any experience with that over there yet?
Yeah, in vitro we have experience in vitro, but we have it not yet CE marked, so we can't use it at the moment. But I think in the future it will very help. It would be very helpful, especially in those cases. Yes, I completely agree.
Now, this is one of those rare cases
So,
where the
as
U.S. actually has it before Europe.
Yeah,
Very, very small
rare.
victory.
Okay.
Very rare.
Okay, as you can see, I have now the Wirebahn in place, and maybe you know the deployment of the Wirebahn is not too easy, because it can happen when you open the Wirebahn with a suture that you create a bend and you pull out the complete stent, and therefore I place my sheath half over this stent to have some support. And now I try to open the stent very carefully and slow. Yeah, now it opens. I go a little, yeah, now okay. So I withdraw a little bit my sheath. I open the next part. And now the last part. So it's open. So, ich hätte jetzt gerne einen 6x40 Ballon, bitte.
Ja,
zeigen,
das ist
ne?
ja nett.
Again. So I withdraw the pusher here from the wire barn. Eine Vergrößerung weniger. We have to control that we don't lose this very important wire.
Is it your choice to always deploy the Viabon or your branch stent first before your aortic one? Or some people would try to deploy them at a similar time to try to avoid some of the issues that you're describing
Yeah.
of losing access or losing
Yeah,
your cannulation to the branches?
Yeah, yeah. When I use balloon expandable stents like Advanta or something else, I like to first place my aortic endograft and keep the sheath inside the target vessel. And then I can have a look which exact length I need for my chimneys. And then I place the chimneys under protection of the sheets. Yeah, but in this case, I was not sure how it works. And therefore I decide if we run in trouble with this, that we can't place a wire barn or that we have some issues with placement, therefore I decide to do this first here. So now we place a balloon here. It's a 6 millimeter balloon. Go to, not too high, 6.
6, yeah.
It's only to have a safe access here.
6.
Great. Ja, okay. Check. Ja, da bin ich vor Ort. Kannst du ein bisschen rotieren, dass ich die Schleuse sehe? Geht das?
Ja, andere
Ich bin aber vor Ort. Okay, alles klar. Okay, jetzt. So, over the deflating balloon, I access my sheath here. Okay, like this. So, and I think now we have a very safe access. 7 mal 22 Advanta. Zeigen. Okay. Ist das Vakuum? Hier? Low lip.
To your point,
Sure,
we
yeah.
always do the opposite.
So I withdraw.
For the balloon mounted, we feel free to deploy without the aortic endograft in place. But for the self-expanding, we always deploy the aortic graft first because they're so flimsy. We feel that they can, especially if you're in an aneurysmal segment,
Yeah.
they'll really drop and you can lose everything.
Yeah.
They'll
Okay.
collapse.
They'll change their length. They'll go to the other side. They do all sorts of things if they're not pinned by something else. Especially if you're in a big sac. I mean, here they're in a normal segment of aorta and a little more constrained.
Yeah, the only thing you have to be careful if you're using a TX2, I have gotten the pull string for the Viabon caught on the fixation
On
of
the
the
hooks.
TX2 once it's fully deployed and you're still deploying the Viabon, which makes it much more interesting.
So now I prepare the balloon expandable stent. I take an Advanta, a short Advanta, and then I can adjust this graft when I have my aortic endograft placed. Gut halten, ne?
Perhaps a question to the other experts. Do you use a relining in any case if you use a Viabon?
I always will reline a Viabon with generally a self-expanding stent unless I'm using the VBX Viabon, which is balloon expandable.
I think it depends for
Noch
me.
ein zweites nasses Tuch, dass es nicht rutscht.
The Endoleak AFX is very compliant. We never ever will reline the Viabon
Okay.
with the AFX. It works out really nicely. On the other side of the extreme, the
ich kann
Valiant
hier.
has a lot. It's very stiff and has a lot of radial forces. So with 100% time, all the time.
Yeah. Ed, question on the AFX, because this is something, I agree that 99% of it's very compliant, and you're going to get a great seal, you get good, obliteration of the gutters, but it's that very proximal ring. And I always worry, is that going to have radial force and compress my graft if I don't reinforce it? Have you found that to be true at all?
I haven't had a problem with it.
Atemstillstand.
Well, I think the relining is not just for to enhance radial force, but I think especially if you're balloon expandable stents, I tend to really make sure that I extend it beyond the end of that first stent to avoid any kinking or problems later on.
Stehen lassen,
That
bitte.
transition, I think, is very helpful.
You know, people kind of discuss the eye of the tiger, where you'll come in and you'll actually dilate up a balloon expandable stent and then put a smaller balloon in, and then when you use your code, you kind of make a round stent into more of an oval. Has anyone tried that?
No.
Okay.
Sorry, not to be the voice of the administrative side of things, but you know, every one of these stents we put in adds another several $1,000s, and eventually overrides the DRG and becomes a money loss. So I think it's important to be cognizant of how many devices we put in.
Ist nicht schlecht.
Ja.
Well, I do like how you've changed your
maybe
II
I
to
can-
really line up your stent grafts so you know exactly where it is and there's no parallax. I think that's an important key also, is you don't want to have it where it's kind of deploying on an oblique angle.
Die lassen mich nicht dazwischen.
No, and really at that point, you really maximizing that neck that he's trying to use. I mean, he can get really to the edge of that left renal artery, and
Unten mit dem
maximize
Abstand,
his
das ist eine
seal.
Autotunneljackhalle, ne? Da gibt's ja keinen.
Which if he takes it to that level, he's right at the level of his Viabond.
So maybe I can explain the next step here.
Yes,
I
please
just
go ahead.
Start to deploy the aortic graft, and if you can switch to the fusion monitor for a second, you can see. Can we switch to the other monitor?
The upper
Yeah,
one.
now you can see we have. It's very helpful to have this fusion technique, and if I can make an overlay, I don't know why it doesn't work. Yeah, you can see it's very exact, and you can see also the yellow ring, and it shows me how the top will at the end sits. So I try to go very close to the left renal artery. At the moment, the points are not very well aligned here, so I try to bring them all in one level, like this. And
how long
I
is your
put
cuff?
another angio, 10.
70.
I think
70
it's
millimeters.
70 millimeters long.
Does anyone remember the distance of the talon main body?
Atemstillstand.
The distance
The
of the
body?
main body of the talon?
4
I can't
centimeters.
remember.
They all, but this is an AUI, so. Yeah,
Something to really be aware of.
yeah, yeah.
A little bit. So I am 2 millimeters too high, I think. So I go a little bit deeper here. Maybe like this.
Soll ich den
And I open the rest of
Finger nicht
of the graft. It's a tube, you know. So I think now it's open. Yes, it's open now. I go in the better magnification here. And we do a last control angio. Atemstillstand nochmal, bitte. Yeah, I think this is okay. So we withdraw the pigtail catheter. Müssen auf die Schleuse achten. Ne?
Zeigst du mal?
Great, okay.
Can I ask what percent oversizing
Okay.
you use for the cuff?
So we try always to use about 15 to 22%. Means if you have a 30 millimeter aorta or 29. So, okay. So now we have placed our aortic graft. I think one important point is when you extend an old endograft repair with suprarenal fixation to cover, if possible, the whole bear springs. Because if you don't cover the whole bear springs, you may have some endoleakage from above. So we can park this now. So, and now we have to finish the chimney grafting. Okay, komm noch mal rüber. Müssen wir einmal rüber.
Dr. Austermann, are you going
Okay.
now to make a kissing ballooning of the stent graft and of the cover stent?
Yes, yes. But first, as you can see, I just placed before the Advanta because I was not sure that we are high enough with the wire barn. But now you can see already the wire barn is above the coverage of the endurance cuff. But we have already the Advanta in place, and therefore I use this stent to reinforce the wire barn, that it will squeezed over time by the aortic endograft. And if the wire barn would not be long enough, I also could extend the stent. But in this case, I don't have to do this. Dilatieren, zügig. So as you can see now, we inflate our Advanta. Ja, reicht. And I try to go inside the graft again. I think very, very important is if you use a cuff or an endograft with suprarenal fixation, that you are aware that there are some material above your chimney. And I never withdraw any balloon or any device without protection of the sheath. And it's very important that you have your sheath always as a protector. Yeah, and yet you can see now we are inside our balloon, and now we can change for the 16 French sheath from below.
I think it's a very important
And then we will
message
perform
to-
the kissing balloon maneuver.
Yes, that's a very important message, to have the wire into the target vessel and also the sheet inside the cover stent, whatever you have or you want to deploy, first the stent graft or first the cover stent.
Yeah, maintaining that protection is critical for any of the maneuvers.
And I think riding the shoulders of the balloon there is a great way of doing it, because if you don't, you just try and advance, you could snow plow and then just crunch everything down below the level of your
Reliant.
cuff. One quick question just for your thought process. A simple a singles fenestrated or fenestrated with a scallop laying going higher, when would you do that versus using a snorkel as you're doing now?
May I answer this?
Yeah.
I mean, in this case, we have an asymmetric origin of the renal arteries. If we want to do, or we want to perform a fenestrated graft in this case, we need a cuff with at least 2 fenestrations, sometimes with 3 fenestrations. The second point is the severe angulation of the iliac arteries on the right side. You have seen the 16 French sheet couldn't go through. So this would be an advantage in this case. We used a very flexible endurant, which without any problem comes through. So we have so many, and another point in case of type 1 endoleak is the position of the bear stent in front of the renal artery. In this case it was just below, but in other cases we have the bear stent in front of the ostium of the target vessels. So this is another point for the parallel graft technique and not for the fenestrated graft. But I have to confess that for this patient originally we wanted to implant a fenestrated graft.
I think one other concern, just like you're mentioning, I think the anatomy around the renals was sort of reasonably suitable, but by not having access to the other femoral and only having limited access from above, from a fenestrated reconstruction standpoint, it may make it more challenging to be able to, because you need to come around the device from above, be able to cannulate before you fully deploy. And this, at least in this situation, seems to be a very reasonable option.
Yeah. Absolutely, and we have also some sealing zone between the origin of the renal artery. So if we lose the right renal artery, well, the other one would be perfused. So in this old man, we decided for this technique.
Okay, dann nimmt den zurück. Ne?
I think that's a very good discussion of the different options as you go through this, because obviously you have to think about all these things. They're saying, do I want to do a fenestrated with scallop? If you can have a scallop, you can actually enter back in and go through the fenestration from above. And that would be one other way of doing it. But I think the size and everything else certainly makes this probably the best way of going. The question was somewhat baited because I'm going to take the liberty and actually cancel the 9:20 talk so everyone's aware, just so we can try and get back on time. I think those topics are going to be covered by the other speakers anyway.
Yeah. I guess the only other point is if you happen to have access under be a physician sponsor ID or some other reconstruction to have a preloaded fenestrated device, then you would be able to do something like this, maybe a little bit easier without having to, as you said, come through a scallop or through the top of the device, etc. If you thought that a fenestrated reconstruction would be the better option for the patient.
Das ist perfekt. So eine Angio machen. 15 bitte. Mach ruhig ein bisschen mehr Übersicht,
Ja,
dass wir beide Nieren mit Peripherie sehen. So now we are going to do a control angio, looking at both renal arteries.
Okay, Atemstillstand bitte.
Geh ruhig ein bisschen höher noch, ein bisschen höher. Gut. Okay, lass noch mal ablaufen. Okay, left renal artery. I think both renal arteries are open, and I can't see an endoleak or a gutter here.
It looks like a good.
I think in this region we are ready. I see also the SMA. So I think we could leave now the chimney stent. We had done a kissing balloon maneuver with a reliant inside the endurant graft and with the stent balloon in the chimney graft. And I think here we are ready now. And we would go now for the left iliac artery.
Okay.
Okay.
But can I ask, before leaving though, do you routinely do a spin to look under high resolution at that chimney and make sure that you don't have any kind of kinking or compression? We find that sometimes, especially, we use the fusion as well, but I think that completion, in addition to the angiogram, the control angiogram, a spin is a nice sort of check.
Okay, KM. Mach nochmal eine RAO von der rechten Niere. So I agree, before we leave the right renal artery, we do a selective angio. Mach mit Niere gleich, mit Niere. Without the Rosen wire. Atemstillstand bitte. So I think
Weiteratmen.
it's okay, and we can leave now this part and go for the iliac aneurysm on the left side. Okay, wir ziehen das hier raus. Ne?
Well, thank you. That was
Okay,
a very interesting, very well constructed reconstruction to be able to salvage this situation.
If you like, and if we have time, we in this morning we did a second chimney case, and if you like, we can go just through all these imaging. It shows very well our
Fall
technique
davor. Der Fall von heute Morgen.
in comparison to this case. Maybe Stefan, you can present the case from tomorrow. Can we have the slides from the case from tomorrow?
Tomorrow or today?
And switch.
I think we need to move on with our program here. We're a little bit behind. Maybe next time we come live, we can have that queued up and we can look at that also.
Okay, I agree.
All right.
Thank you very much.
Thank you
Great
very
case.
much.